This week on the Backtable Podcast.
And I think for me, like if at 6 months they are having no movement, then I will move forward with surgery. And for me, it'll definitely be a 5-7, possibly including some fascial lattice suspension, possibly a cross-facial nerve graft, possibly a partial hypoglossal. I don't think waiting a year helps, and I think it might harm the level of improvement that we can get. At the same time, if they have any movement, even slight twitching at 6 months, then I hold off, because even slight twitching, I think it's a sign of reanimation that will continue to get better with a little bit more time.
Hello, everyone, and welcome to the Backtable ENT Podcast, where we discuss all things ENT. We bring you the best and brightest in our field with the hope that you can take something from our show to your practice. Hi, friends and colleagues. We're thrilled to announce the launch of Backtable Plus for ENT. Backtable Plus features bite-sized learning modules created by ENTs for ENTs. The content is designed to be searchable, organized, and easy to digest, making it perfect for our busy schedules. Best of all, it's completely free. We encourage you to explore the platform and share your thoughts with us. Go to plus.backtable.com, plus.backtable.com, and click on ENT courses. Your feedback is invaluable as we strive to make this resource as beneficial as possible. Happy learning, and we can't wait to hear what you think.
My name is Shiayin Yang, and I'm an associate professor of facial plastic and reconstructive surgery at Vanderbilt University in Nashville, Tennessee, and I have the pleasure of being the guest host for today's episode. It is my distinct honor to be able to have Dr. Myriam Loyo Li, who is a colleague and personal friend on the show. She's a facial plastic surgeon at Oregon Health and Science University. She's an associate professor in the Department of Otolaryngology, as well as the co-director of the Facial Nerve Center. So welcome, Myriam. It's good to see you.
Same. Thanks for having me, Shai.
Of course. And today's episode, we'll be discussing surgical management of flaccid facial palsy. So I guess for our listeners, if first, Myriam, you want to just give us a definition of what exactly is flaccid facial palsy?
Sure. When I hear you ask about flaccid paralysis, I think about weakness, like either a patient's completely flaccid and they're not moving at all, or they have some degree of weakness where they can't quite move their face with a normal strength.
For our listeners, if you have someone coming into the office and you're thinking of management, just kind of go through, how do you evaluate these patients, and then how do you determine, what you're going to offer them? So let's say someone comes in, their face, they have weakness, it's not working. How does that consultation go with these patients?
Sure. I think the first step for me is to figure out if they're going to recover spontaneously or not. Like, do I think this condition is going to improve on its own, or it's likely to stay as it is unless I do some intervention? And I guess that was probably where you were coming in with your question about flaccid paralysis versus non-flaccid paralysis. So we can have people that were flaccid before but have now recovered and have spasms or synkinesis, or mixed picture of weakness and coordinating movements, muscles that are coactivating what they shouldn't be. So for me, still the number one cause for flaccid paralysis is Bell's palsy. It's the most common cause of facial paralysis. And for every one person that I see with a tumor, with trauma, with other etiology for their paralysis, I probably see 40 to 50 people with Bell's palsy. So if somebody comes in and they're flaccid, usually what I'm trying to figure out is if this is Bell's palsy or something else. And then if it is something else, then do I expect it's going to recover on its own or not? And then from there, figure out a treatment plan.
How long for your Bell's palsy patients do you wait? Or what do you tell them? When do you expect to see some type of recovery for them?
Yeah, so for all Bell's palsy patients, you should see some recovery. It's not uncommon for patients to say, I just never got better. I'm still suffering from Bell's palsy. When they have had some recovery and tone, just not a complete recovery to normal pre-injury function. But for us as the doctors, as the otolaryngologist or the facial nerve surgeons, all Bell's palsy patients should have some recovery. In general, I think the longest it should take is 6 months. I have had one person that took more like 9 months that has been the only one outlier that I've ever seen. And he has a neuromuscular dystrophy. So I really think that he was reinnervating before, but his muscle fibers were just not taking that reinnervation. So in general, by 6 months, somebody with flaccid paralysis should be starting to have some movement.
So just in terms of guidelines and getting some type of imaging, if they don't have any recovery, are you usually getting an MRI around that 6-month point?
Yeah, our academy, the American Academy of Otolaryngology, Head and Neck Surgery, put out some really nice guidelines. So by 3 months, if there's no sign of recovery, then I'm typically getting imaging. And then, one of the pearls about getting the imaging is that we really want to image the whole course of the facial nerve. So brain, base of skull, and face. And I have picked up on tumors like that before for somebody that's been told that they have Bell's palsy and they have a parotid tumor or a more anterior or base of skull tumor that wasn't picked up by a brain MRI.
So I guess now going down this pathway of our patients who are not, the Bell's palsy or who don't expect recovery, let's say you see them within the first couple months, what's kind of your next pathway for treatment for these patients, or, what do you tell them?
Yeah. So if I know the nerve has been sacrificed and it's completely disconnected and it's not going to get better on its own, then I'm typically trying to intervene as soon as possible. I really think that the faster we can get in there and bring back innervation to the facial muscles, the better the recovery will be. So sometimes I'll have a vestibular schwannoma or a CPA angle meningioma, where the surgeons know that the nerve has been transected and are not expecting recovery. I'll probably intervene in those patients fast. And then sometimes my preference is always to be able to do the reconstruction for a cancer patient, like a parotid cancer patient, at the same time. But I do sometimes get people who have been treated in outside facilities, and then we'll just try to go as soon as we can to try to reinnervate the face.
Okay. I think the cancer patient's a good point. I'm interested in, typically in my practice, if it's a cancer patient who has some portion of the nerve transected, trying to, either coapt the nerve together primarily if you can, but if you can't, then cable graft it. And I know there's been different ways in terms of types of grafts you can use, as well as adding additional nerves such as mesenteric. What do you like to do in your practice for those patients?
So for my practice, it's rare for me to have a branch that has been transected. Most commonly, I'm being called when the main trunk is missing and it's a large segment that's missing, probably around 6 centimeters of facial nerve there and missing. In that scenario, while I'm still doing the cable graft and hoping to get some recovery, I will always add a nerve transfer, most commonly masseter, sometimes also partial hypoglossal. And then I'll always add some static suspension. The reason I do that is I feel like the cable graft is unpredictable. Sure, I have seen patients where the cable graft had some beautiful return of function, particularly in younger patients, like 30-year-olds, but those are rare. And so I really want to give them a better chance of getting some return in function by adding the masseter to facial. And then I really like adding the static suspension because particularly if they went in with normal facial function and they wake up and they're paralyzed, the fact that they have the lift and the static suspension really helps decrease the morbidity of the sag and the dysarthria, the dysphagia. So I tend to do fascia lata slings for the mid-face and try to leave the oral commissure undissected. But here there's options, Shai. So I'm curious, do you do temporalis tendon transfer? Do you prefer doing partial hypoglossal? Do you try to do both mesenteric and partial hypoglossal? Because I think they're all valid options to use in this case.
Yeah, I think my biggest use is mesenteric and a static sling because, like you said, most of these patients are older patients. They already have facial droop. I do find it takes a while for them to get recovery back, and they usually don't get great recovery of the forehead, I see, and a lot of them have mid-face droops, mid-facial droops, so that lower eyelid is already being pulled down just from natural aging. So those two parts I do use a lot in my practice. I'm curious about the hypoglossal because I haven't done that. Are you just doing a cable graft to hypoglossal to the main trunk of the facial nerve, or how are you deciding to incorporate that, and how exactly do you do it?
Yeah. So I was very cautious in using hypoglossal for a long time because I have seen people with very severe dysarthria and dysphagia from tongue weakness from hypoglossals done sort of back in the day. I really think that now that we're doing like 20, 30% of hypoglossal, it tends to have much less morbidity. Now, our head and neck cancer patients are a slightly different population. If they have a large resection, they're already missing soft tissue and muscles in the face, they definitely can have worse dysphagia. Most of the times when I'm doing reanimation for a cancer patient, it tends to be a parotid cancer. So either a squame that metastasized to the parotid or a primary cancer of the parotid. So they're not having particularly other sources of pharyngeal dysphagia or tongue weakness or things like that. I'm not a surgeon that will commonly add the hypoglossal at this stage, but I know that others are. And what I think we can gain from doing this, from doing like mesenteric in also the hypoglossal, is more tone. So I think the hypoglossal will provide more tone and allow us to reinnervate other branches that perhaps the mesenteric couldn't get to. So the places where I've seen myself using both mesenteric and partial hypoglossal have been where I don't have a proximal nerve. So the proximal nerve has been is still positive or has been drilled out all the way to the mastoid and we still can't find the stump. Then I won't try to cable graft all that length. So I'll use the masseter for kind of like a higher mid-face branch, and then I'll put a partial hypo to a lower branch. And at this point, I'm trying to be efficient and fast and minimize more dissection. And so I will put just a cable from hypoglossal up to a lower kind of buccal branch for the facial nerve.
Yeah, I mean, which makes sense because if you have a patient who has that, big of a tumor, they likely have a positive, the nerve is likely going to be positive. And especially if they're sacrificing that much of the facial nerve.
Yeah. And this has been a little bit of like a point of discussion for us at OHSU, just because our head and neck surgeons wanted to make sure that we weren't just prolonging the surgery and making it more complicated in somebody with like a very scary, advanced tumor that is likely to recur. And we've been pretty impressed that, to put a cable graft to a partial hypo doesn't add a lot more time. And patients really do get reanimation. And even if they have recurrence of their cancer, they still have better function while they're having to live through that recurrence. So, I want to be mindful that we're not just making these surgeries for patients that are going to die of their disease, like extremely long and complicated or adding morbidity. But I think it really can't be done in a way that doesn't do that, but rather gives them more quality of life.
I think that's such an important point because, we all know that patient who is in their 70s or 80s and already, very poor health, and you're trying to get them off the operating table. They have multiple medical comorbidities, and we opt not to do a facial reanimation because we think, oh, this is going to recur or they don't have much longer to live. And I think that's such a huge point to say, this is a quality of life and it's going to affect them significantly. So yeah, I think being able to find that balance is probably something I haven't quite figured out yet. And, just with more data and research and how it really helps them can be really impactful for patients. But it's definitely a hard or a hard balance to figure out.
Yeah. And I think that's one of the areas where like all of this virtual care has really helped me to kind of try to have those conversations with patients. So before, it wasn't uncommon for me to operate on somebody that I might not have had the chance to really meet and talk to before, and just kind of be evaluating the defect, how much of the facial nerve is missing. And for us, around 50% of people have preoperative facial paralysis before we go in there for their cancer, and 50% don't. They had normal function. But with virtual now, we've been able to connect, and I learned so much about people and their kind of like preferences and expectations. Like, I can remember a guy that was like a woodworker, and so for him, the eye protection and getting it done immediately was like super important. people that had to be in like board meetings and were speaking and preserving and making sure that they had no tongue weakness and no risk was a priority for them. So totally agree with you that following the patients longer and paying attention to what their quality of life and the things that matter to them, and then the impact of this fine choices, between like masseter and hypo, not just reinnervate and not reinnervate, and looking at length of time in surgery and other comorbidities really will help us choose better for our patients.
Yeah, for them. What do you use for your cable graft?
For a long time, we were not doing any, I took a deep breath right when you asked this question. I was like, what do we use for the cable graft? So at OHSU for a long time, we were not putting any free flaps to reconstruct the volume deficit. So even though it's a large volume deficit, we were not, and it's a lateral defect, right? It's not in the center of your face. And the patients had a lot going on. But I think we were a bit of outliers in that. I think the majority of the academic centers in the U.S. were putting free flaps on those patients. I'm curious if you guys were shy, probably.
Yeah, I think it's a combination of both.
A combination of both. Okay. Because we weren't, then I was really kind of being creative with the nerves around this area. So I would take long greater egg or some cutaneous branches from cervical rootlets to connect, or contralateral greater egg. But now we really have moved towards doing ALTs. Our microvascular team is really fast. They can harvest and inset very quickly. So Mark Wax has been here for a long time and has been doing that work really beautifully. And we just hired Sarah Yang, who's also part of our microvascular reconstructive team. So they're doing that, and they'll give me the nerve to vastus lateralis. And then now I have a motor branch to use. So that's been a really nice finesse and upgrade that we've been doing to our surgeries.
So I'm curious, because this is something that I talked about in fellowship, and it's still something that I'd like to look into, is have you noticed a difference in terms of, really seeing that time to reinnervation with a motor nerve versus a sensory nerve, because commonly if you're doing a cable graft, most likely you're using greater Rick, or if you can't use that, sural nerve, which are both sensory, but the facial nerve is a motor nerve.
Yeah, great question. I wish I could tell you the answer to this. So like the theory behind it being like, if we're using a sensory nerve, is that why our cable grafts are not doing as well? If we're using a motor nerve, can we get more growth through that? And I think my volume is small where I can't quite separate and study that and tell you. And so that's a part where I think like if all of the centers are doing this kind of super rare, highly complex surgeries, if we pull our data together, we'll be able to start getting more answers.
Because that's just something that, I think there's multiple unanswered questions in facial paralysis, and that's definitely one of them.
Yeah, which cable graft to use and does it make a difference? And then do you flip it so that...
Exactly.
Yeah.
Just another, since we're on the topic, what about how do you do your neuroorphy, and then do you use anything to cover it?
Yeah, that hasn't been an area where I've done a lot of research, so I might be a little outdated, but my preference is just to put nylon sutures and then use a little bit of Teciel around to reinforce. And I'm trying to put them together with minimal tension to not bunch up the accents, but rather just have them sitting, opposing right next to each other, and to put the stitches in the epineurum.
Yeah, I'm curious because we always used little vein grafts, and so easy. Just take a little bit of the vein, in the nearby field to cover up, do your neuroorphy, and then cover that. But now there's newer things that have data in hand literature and with Axogen. So it's always curious, what is the best way? Do you have to sew it to like minimize how much you handle the tissue and the potential damage? It's definitely an area that I think could use some.
Yeah, and I haven't, as I said, I haven't looked at the literature recently, but I think this balance between like, how can we reinforce that coaptation so that we guide those accents towards each other in a better way, and so that they're not just spreading out and getting lost. And then how do we do that so that we're not creating excessive inflammation and scarring, so that it doesn't make it harder for the accents to grow through that area. And, when I was a resident, which now is like 11 years ago, they were doing animal trials at Hopkins where they were comparing different techniques. And honestly, a lot of coaptation
technique. Okay.
Yeah, exactly. Yeah. And there was a point where you were just creating more inflammation, and it wasn't truly helping. I think there's some really cool research happening looking at could we have some sort of sheet repair that's surrounding the neuropathy and has neurotrophic factors that will promote axonal growth. It's a little bit hard to think about using that in cancer, but I definitely think that how do we enhance growth in our nerve transfers? How do we enhance growth in our kebal grafts? Is definitely such a cool area of research that is going to be getting better and better in the next decade. And so definitely the tubules that are coated in growth factors, I think, will be something that we'll be hearing more of. My center, OHSU, has been collaborating with Cleveland Clinic that they have a randomized control trial on intraoperative brief electric stimulation. And so we are a site that's recruiting. And so not for kebal grafts for cancer, but for cross-facial nerve grafts, we're using brief intraoperative electric stimulation to try and enhance growth. And hopefully we'll have some preliminary data to support its use.
Interesting. So what, when you're putting in your cross-facial nerve graft, are you stimulating like the disc? What are you stimulating?
Yeah, so you go proximal to your neuropathy or coaptation, and then you stimulate for 10 minutes. And the idea is that the stimulation will go retrograde towards the nucleus, and then that will sprout for their axonal growth. And it's based on animal data. And then there are human trials that have shown that this type of brief intraoperative stimulation improved motor repair after carpal tunnel surgery, after digital nerve repair, and even stretched spinal accessory nerves in a neck dissection. Not only and the outcomes have been like functional recovery, like hand grip and strength and shoulder strength, even like a year after the intervention. So it's pretty exciting stuff.
So what are the outcomes are you looking at? Are you looking at clinical outcomes in terms of like how quickly are they demonstrating a Snell sign? Or are you also looking histologically when you do your second stage at the nerve? How are you guys measuring this?
Yeah, I mean, bingo. Like that's why the model of the cross-facial nerve graft is so exciting to study. How do we improve growth through our kebal graft? Because we have that second stage where we can biopsy the distal tip. So electron microscopy to look at axonal growth at the distal area. So really, this has been Patrick Burns' project. He really started at Cleveland Clinic, and the background data from animal data and the humans trials are there. So I'm hopeful that we'll find the same for the cross-facial nerve grafts. It's really exciting, and we've just started this year, so we will for sure have more data and more information to share on this.
Yeah, that sounds awesome.
And Shai, I mean, like that's the hard thing about facial nerve, right? The cases are rare, and like if our outcome is like how well they move their face or how wide their smile is, it's really hard, right, to compare outcomes like that, even with the amazing technology that we have nowadays, even with eFaces and Emotrix, and with the dedicated, validated quality of life questionnaires.
No, I mean, it's so true. This gives you like quantitative data, histologic data that you can look at. And I mean, you said it perfectly. It's so hard to measure our outcomes because there's so many different factors we're taking in. And even if you as a physician thinks, oh my gosh, you have a beautiful smile, or, the face has balanced so well, the patient may feel completely, may not agree. And so, yeah, I think that's really exciting research.
Yeah. And as I think of it, like, yes, like in my ideal world, like we'll be studying facial outcomes by, combining different centers. And then we'd look at the clinician ratings, the objective photos, the patient perspective. And then maybe even this like new area where we're like bringing naive observers to look at faces and see what they think of them.
Well, actually, a nice thing and something that, I've started looking into is how can we incorporate machine learning and AI? Because on your phone, you just have even facial recognition. So, it's something that Apple has already, figured out, and it's something that we can easily incorporate to better study trends among patients. And then if you can do, like you said, these are rare cases. And so if you can pool data across the country and then have some type of machine learning or AI to process it, that can really, excel our understanding of facial paralysis and, our outcomes and, what do physicians think? What do patients think? I also, it's just such a big reason why facial reanimation is such a fun topic, because there's so much to do to improve our current treatment. And I'm sure, in 20 years from now, the stuff we're doing is going to be very outdated.
And why we love being facial plastic surgeons, right? Like, because it's their faces and how we communicate with each other. As you're sharing all this stuff, exciting stuff that you're doing with artificial intelligence, I was like reminded of a patient who I did a nasal reconstruction, so not facial nerve, but she refused to change the Apple ID so that her phone would recognize her. And one of her measures of success that we've done a good surgery was because her phone started unlocking and recognizing herself.
So crazy.
Yeah.
Yeah, I mean, but that's the difficulty with facial plastics, is you're not the only person judging the outcome.
Yeah, and the challenge and the reward, like so much of our identity, our face and how we move and how we speak.
And how we communicate. Yeah, that's really cool. So I guess going back to
the topic,
going back to the topic. We just discussed, you saw a patient, they're flaccid, the nerve is cut. What about that patient who is flaccid? They had a surgery, let's say a tumor, and they think the nerve is intact, but they can't give you 100% yes or no answer. Let's say you're seeing this patient at 3 months. What do you do?
Yeah, so I think our traditional teaching, or at least mine, had been to wait a year. So somebody had a vestibular schwannoma, we would wait a year, and then at 1 year, if there was no reinnervation, then we would intervene. And I think that has really changed for me. I'm intervening at 6 months. And there's good data from Hopkins, Kofi Bahini, that the study where he would offer early intervention in 6 months and then followed patients in. So those that declined the intervention at 6 months were followed to a year. And it's a small case series, but still nobody that had no function at 6 months then went to develop it at 1 year. So if you think about what we're doing with vestibular schwannoma, we're really going to find one branch and leaving the rest intact as it is. So if there was going to be further recovery, we're not harming that further recovery. So for somebody that at 3 months has no recovery of function, I'm already working on their periocular health. And if they have developed ectropion, I wouldn't expect that they would reinnervate and it would all of a sudden lift the lower eyelid. So I'm doing that type of interventions already. And we're talking about doing a nerve transfer around 6 months if there is no recovery.
And then can you define for our audience, what nerve transfer are you doing at 6 months?
Yeah, so most commonly it's 5/7. Sometimes I'm setting a first stage cross-facial nerve graft. And one of the reasons I do that is because I'm using the masseter as a babysitter and then plugging cross-facial nerve graft as a second stage. And my thought is that I'll be able to get more spontaneity of movement on the paralyzed side by using the cross-facial.
And so where are you connecting your masseter and where are you connecting your crossface?
Yeah, so I typically connect my masseter to the largest mid-face branch that I can see. It's typically easy, right? They're sitting right on top of each other. So as you're dissecting in way and route to isolating the masseteric motor nerve, you'll find the mid-face branch that you're looking for the facial nerve.
Because I never get enough length on that masseter as I think I'm going to get.
Under the microscope, it can look like you have such great length, right?
And then you pull it out and it's like, this is not going anywhere.
I mean, in vestibular schwannomas, it's easy, right? Because you can trace the facial nerve more proximally and get the length like that. Yeah, and I wish I had tips for you, like, okay, how do you get that masseter to be longer? But I suppose it would be like, sometimes I do remove masseter muscle. It's going to atrophy anyhow. I'm going to denervate it. So I'll freely debulk the masseter muscle to create more space. And then sometimes I'll remove a little bit of parotid to allow the facial nerve to move a little bit more.
And then with your crossface nerve graft, where are you connecting that to?
Yeah, so I mean, in the traditional sense where the babysitter was first described was a hypoglossal, where the hypoglossal nerve was being used early to keep the neuromuscular junction and facial muscles alive, so to still get innervation to keep them moving. And then you would come back and then use a cross-facial nerve graft. You would undo the hypoglossal and put the cross-facial nerve graft. I'm not quite doing it exactly like that. So I will still leave the 5 to 7 connected. I will just choose one of the branches from the 5 to 7, and I'll plug the distal tip of the cross-facial nerve graft there. And then sometimes you'll see a little bit of the cross innervation. Like you can stimulate directly where the 5-7 has happened and stimulate sort of like proximal to your neuropathy, and you'll see what moves. And then you can go distally, and there are other branches that now are kind of cross that will stimulate, and choose one of those. And I don't have large case series to tell you like it definitely works, and I'm definitely added spontaneity.
I'm curious because I truthfully haven't loved my cross-face nerve grafts. And I'm wondering how, because there's that argument, does masseter give you any spontaneity? I think most would say no, but I think some say you might see a little bit. And there's actually been a study where they did a EMG analysis and showed that with chewing, you actually do get some activation of with oral commissure excursion. So, could that be the spontaneity you're seeing? But yeah, I just haven't had a ton of great success with my cross-facial nerve grafts. So I'm curious what, I assume you think it helps since you've been doing it.
Yeah. I mean, so I think it helps, but I don't know for sure. I really do need to study it for longer. I definitely think that in my younger patients, I'm much more excited to try it. So, I have vestibular carcinoma patients that are 28 years old, and so I think a cross-facial nerve graft on a 28-year-old with no radiation, a very different scenario than what we were talking about just a minute ago.
With our parotid patients.
Yeah. We also have vestibular carcinoma patients that are in their 60s or in their 80s. And so I think their regenerative potential for that cross-facial nerve graft will be different. So I think I'm seeing more spontaneity of movement with adding the cross-facial nerve graft as a single stage after using the masseter as a babysitter. I don't know.
And what time point do you add it?
So I normally let them get as much reinnervation as they're going to get from 5-7. And they're usually tired from surgeries, They just had a craniotomy and then
surgery.
Yeah. And then they just went through another reanimation. And so I'll just let it be as long as it's working well. And when they say, okay, can you do something else for me? And say like, well, we have that cross-facial nerve graft there, and check the tunnel and look at that.
Are you adding hypoglossal? Like, let's say they're at a year, they have great excursion, but they're still completely flaccid, or not, they don't have good tone, I should say that. Are you adding hypoglossal then? Are you offering hypoglossal at a year?
Yeah. So traditionally, I was not doing the masseter and the hypoglossal at the same time. That has shifted for me. Now I will offer it to patients. And, a lot of the patient decisions will depend on how we present it. So I feel like I'm presenting it more favorably, but I'm much more, I guess I will say, like, I really do advocate that they undergo 5 to 7 at the very least. And if they're looking to do less surgery and they don't want to add hypoglossal, I'll be honest, I won't tell them that. I won't put as much emphasis on why I think it's so important. Whereas I do think that doing the 5-7 at 6 months is really important. If they just want to do that and they don't want to add hypoglossal, I won't say, your chances of having flaccidity at rest are much higher if you do this. I'll say something like, okay, like we've discussed pros and cons, and this seems like a good way to go. So how you were saying, like, do we get spontaneity from masseter or do we not? I definitely agree with you that some of us are using our masseter to smile more than others. Just however our brain is made, however our facial structure is made, like we activate masseter more when we're smiling. I think it's possible that people that do that we just are masseteric activators during smile get more spontaneity when we're reinnervating them with 5-7. There is plasticity, and the nucleus of the facial nerve and the trigeminal nerve are close by. There's probably some people that are more plastic than others. I think my favorite study for smile spontaneity is Hadlock's study with Drusseldorf, where they did the spontaneity assay. So they showed patients this like little funny video clip, which is really funny. It's like this little baby that's giggling. Like if you've never watched it, you totally should. Yeah. And, some of the people innervated by masseter were spontaneous. It was a lot less than cross-facial, but a small group, if I remember, maybe 20%, this is just going off the top of my head, had some spontaneity. And then I think Hopkins and Nina Liu and Kofi Bohini looked at tone for masseter. And I want to say it did depend by age. So if they were over 50, then they were more likely to only get, like, if they were very, very flaccid, they would only get a half of the weight correction with masseter only. And so I will add some static suspension when I'm doing 5/7s for vestibular phenoma patients where they already are very ptotic and you see the face is really falling off.
Do you know in those patients where they found tone with 5/7, were they doing end-to-end with masseteric to facial nerve?
I can't remember that I read that on the paper, Shai, but that was my impression. They were doing end-to-end with masseter. And, for younger patients, I really don't see that, like, resting flaccidity. So I don't think every single person that only gets a 5/7 will end up flaccid at rest. I think there is some variation there, and I think definitely older patients are more likely.
The challenge with the young patients is that it's hard to tell. Young patients tend to have more tone than our older patients. And so I think it takes a while for that flaccid state to reveal itself.
And at the same time, that side will age a little less, right? It'll have less movement. Yeah.
I mean, it's truly amazing because I have a patient who had paralysis of the upper part of her face, and she had it since she was a child. And the difference between the two sides is striking because she obviously was not moving that part of the face. So she has no wrinkles on the one side and the other, she has these deep wrinkles. But okay, yeah, I think that topic is very interesting. You have a patient who's flaccid. There is some thought that the nerve is could be intact. So I always counsel patients, this is a little bit of a tough decision because as a facial nerve surgeon, it is against your inherent belief of cutting an intact facial nerve, or it is very, very difficult to cut an intact facial nerve. And at what point do we make that decision? And, you touched on it, but just really, making this a decision with you and the patient is so important because their goals and, what they want to achieve may be different than what you think is best for them.
Yeah. And I think for me, if at 6 months they are having no movement, then I will move forward with surgery. And for me, it'll definitely be a 5/7, possibly including some fascia lata suspension, possibly a cross-facial nerve graft, possibly a partial hypoglossal. And I don't think waiting a year helps. And I think it might harm the level of improvement that we can get. At the same time, if they have any movement, even slight twitching at 6 months, then I hold off because even slight twitching, I think it's a sign of reanimation that will continue to get better with a little bit more time.
Yeah, and it's hard because that the level of synkinesis they're probably going to develop. It's such a hard dilemma. And I also think it's so tempting. You're like, oh, let me put that masseter in there, but there hasn't been that great data to show that it will overpower, prevent synkinesis. But yeah, I mean, to me, additionally, I've had those patients who didn't want anything and they do recover. It just takes a very, depending because of how proximal that injury is with those tumors, it just takes a really long time for them to recover. But then it's hard to predict, how much synkinesis are they going to develop.
Yeah, and I guess I really do think that our patients that undergo nerve transfers will have a better outcome than patients that are going free muscle transfer. But if somebody says, I don't want to do an intervention, I just want to watch it, and they have no recovery, we have the backup of doing a free muscle transfer later.
Yeah.
And I think it's a little different. The people who were having normal movement of the face, undergo a cranie for a CPA tumor, and then have flaccid paralysis that it's not recovering, to the patients that are having progressive decline or changes in fluctuations, especially the facial trinoma patients. I think that slow and progressive decline will do worse with reinnervation than a single injury than we are looking at reinnervating.
So that's another great point you brought up because I recently just had a patient in clinic that I'm honestly struggling to figure out where do we like quote unquote start the clock of your facial paralysis? Because, this is a patient who it wasn't a tumor, but they've had a middle ear disease and progressive paralysis, but they have recovery. So they would have these on and off episodes of paralysis with recovery. Of course, it's hard to remember the exact duration between episodes, and now they're completely weak, but it's like you have this history before of these on and off episodes, and it's hard not to think that it's hard to know how much of those motor endpoints were alive after each episode. And at what point do we say, okay, this is our 6-month point where we start the reinnervation? But then the other struggle is how do I cut your facial nerve if you could potentially get recovery? And I think you could ask, 10 different surgeons and get 10 different answers.
Yeah. And having the conversation with the patient about risk tolerance and kind of like being open about we don't know. Like, this is how much we know and this is how much we really don't know.
So another thing I'm interested in knowing is how often with these patients or, someone you're unsure as to the quality of their nerve, are you using any tests like EMG to see, do they have any reinnervation? Does that play any role in your practice?
I really don't use EMG for the facial nerve much. If I don't see clinical movement, it doesn't matter if they have fibrillations or polyphasic, like even if they're showing some signs of reinnervation. If they're having no movement, then that's really what I go on. I used to use the EMG more for masseter. I tended to really want to feel it, even when I knew it was abnormal. So I kind of used the EMG to confirm, yes, it is abnormal. More and more I know if it's feeling abnormal, it's going to be abnormal. And for some of the larger CPA tumors, it can be not just facial, but also the trigeminal, including the motor branch that is affected. So that's the key scenario where I use EMG more to evaluate the masseteric function in an area where I think there's impairment.
And so is there anything specific aside from just feeling it when they're clenching? Is there any specific thing that you're like, oh, that is, that nerve is not intact or that nerve is not working as well as it should?
Yeah, I think you'll see. I think what I've found is that I'll feel weakness and asymmetry, like it's there, but it's like weak.
Okay.
Or
in comparison to the other side.
In comparison to the contralateral side. And sometimes it's just like, okay, it's contracting, but not as strongly, or it'll twitch in the muscle. And so I think those are the things that make me think that there's been an injury. And they can have reinnervation, but I don't think that reinnervation is as good as a nerve that has not been injured and had to go through reinnervation.
At what time point do you, let's say now this patient comes to you after a year.
Shai, do you use it? Do you use EMG or nerve conduction in other ways?
Not routinely, to be honest. In this patient that I'm unsure about, I am going to use it, but I don't think it's going to strongly change my practice or strongly change my plan. It's more as an additional tool for information. But, I kind of thought through it in my head and, is it really going to change what I'm going to do? Probably not. But if it can give us an additional source of information, it might be helpful. But routinely, I don't.
Yeah. And one of the hard things with EMG is that it's a subjective thing, right? Like they're going to describe this action potential for you and tell you about the abnormalities rather than like a number or a threshold or anything like that.
Yeah, agreed. So in terms of timing, at what time point do you find, or do you have a time point when nerve transfer is not an option? Like what is your cutoff for patients? Or does it vary? Does it vary by their age, their presentation, and their etiology? How do you determine when you will do a nerve transfer versus when you're going to take the next step to a free muscle transfer?
Yeah, great question. And I think we don't fully know the answer, and the answer is probably a little different for every person. I definitely take age into consideration. So for children, I'm much more likely to do nerve transfers, even up to a year and a half. But for adults, when I'm way past that 1 year, I will not do it. And then when I'm approaching 1 year, I'll start having a conversation about either using more nerve transfers, like not just 5/7, but really also using hypoglossal. And there's some data from Dr. Luceta in Spain that makes me think that hypoglossal might do better after 1 year than masseter. And I talk about kind of like expectations and pros and cons and what do they want to do. If they're at that 1 year mark or a little bit further out, then I start telling them that we might get some tone, we might get some few millimeters of movement. Do they want to try that, or do they want to move towards a free muscle transfer? So I guess if I summarize it, it's really hard. There is no cutoff, and they will be different for everybody. I think for me and children, I will be able to give them 1.5 years before I am not going to try a nerve transfer for them. So within 1.5 years, I will do a nerve transfer for a child. And I think for older adults, it's different. When we are past 1 year, I'm not excited to try nerve transfers. And if we are going to do it around the 1 year mark, I will advocate that we use not just 5/7, but also hypoglossal, because I think they will have a better result at that time if we use both.
And then just for our listeners, why is this time important? Explain why we picked that time point.
Yeah. So we think that there's a time when the neuromuscular junction is still viable to reinnervation, and that reinnervation is still going to translate into meaningful movement that we see in the faces. And so the further out we go, the more likely we are to be unsuccessful, to do a nerve transfer and get either no reinnervation or no improvement in tone or movement, or get small few millimeters of movement with some improved tone without actually having a meaningful smile. And we probably want to try to get people smiling like 1 centimeter, and 0.5 centimeter is better than nothing, but less than 4 millimeters is really not ideal.
Yeah, so really just the time in terms of trying to get that muscle reinnervated before those motor end plates die. And I do agree. I think there's a difference in terms of kids and, just the neuroplasticity and how much they're able to recover after these procedures, like with any other part of their body in terms of healing. So now let's go into the free muscle transfer. And, I think this is exciting area, a lot of areas for development. We'll talk about, your most recent study. But in terms of the different types that are available, the most commonly known is the gracilis, which, is probably the gold standard just in terms of free tissue transfer for facial reanimation. But there's been other types as well. So we'll start with gracilis. It sounds like you're usually reserving this for your patients who are more than a year out, for your adults with flaccid facial paralysis who've had no return of movement. Tell me just your overall, what are you using in terms of your neural input to this muscle?
Yeah. So the most common innervation that I will use for a gracilis is dual innervation. And I prefer doing a 2-stage cross-facial nerve graft and then using the masseter. That is my most common choice.
And so, for our listeners, I assume you're using the sural nerve for your cross-facial nerve graft.
I am. At the same time, one difference that I've noticed is that I won't harvest again for sural nerve that has already been harvested. I know other surgeons do. I will go to medial antebrachial cutaneous if somebody has peripheral neuropathy. That's another place where I use nerve conduction. If somebody has diabetes and peripheral neuropathy, I will test their sural nerve. And if it is impaired, I will use medial antebrachial cutaneous nerve. And I guess I should have said that before also.
Yeah. And so how long are you, I guess the question always is like, how proximal do you inset your cross-facial nerve graft on the, affected side? Because it was always like, take, a good branch that gives you upward excursion. You're going to downregulate the unaffected side to give them more symmetry, but you're always like in your mind, like, oh, am I going to make their face? Am I going to ruin their smile on the unaffected side?
Yeah. Like somehow I don't worry about that anymore. So I take a good sized branch that's in the mid face, and there's just so much redundancy in that area. It's really a mesh more than like a single nerve that's going out there. I really think of the nerves more as a mesh than like a pipe. I don't know. So I'm much less concerned about giving somebody weakness on their unaffected side. I've never seen it. I suppose if you don't have a lot of experience with cross-facial nerve graft, you want to be cautious and make sure you have a branch that is robust enough that you will have enough access to grow through this long cable graft, and confirm that you have other branches around the area that are producing the same redundant movement. But I think it would be hard. You really would have to take a lot to be causing weakness from a cross-facial nerve graft. And there's some exciting research that I've been following out of Brazil about cross-facial nerve grafts for direct innervation of the orbicularis oculi. And so in my practice, I've been moving towards a cross-facial for the free muscle, and then a cross-facial towards orbicularis oculi, towards the eyelids. And I don't have enough follow-up to tell you how well it works, but I'm hoping to replicate some of the results I'm seeing coming out of Brazil, where they're getting some direct reinnervation.
So how are you bringing that nerve? Where are you reinnervating it?
Oh, yeah. So I'm prioritizing the upper eyelid, and I'm coming through the bridge of the nose.
Okay. And then are you actually finding a branch to coapt the nerve to, or are you dunking it into the muscle?
Yeah, so we're doing a variation of things, which is also why it's hard to know how it works and when it works. So for people who are not in the free muscle category but are still on the nerve transfer, we'll try to find a nerve branch and do the coaptation there. For people who are undergoing a free muscle, we'll try to put a branch going into the free muscle, like direct into the free muscle. And then there is another group that has published on free platysma muscle grafts for the eyelids, which I was very hesitant to believe in. Like, I'm just going to take a strip of muscle and I'm going to put it there, and it's all of a sudden going to become alive and reinnervated. I think there is something special about the eyelids, that they just have this like amazing vascular supply, and somehow they do better. And our body biologically wants to protect the eye. That's why we get so much blepharospasm and reinnervation there. So I think there's something special there. I think we need to study it a lot more before we start doing things like this that I'm talking about. But I guess my point in bringing up this several cross-facial nerve grafts in a single patient is that it is hard to give somebody weakness in the non-paralyzed side. And I'm moving towards more cross-facial nerve grafts rather than less. Dr. Raquel Baptista has been using cross-facial nerve grafts for eyelid reanimation with direct neurotization, with some exciting results. So we've been trying to replicate some of those findings here at OHSU.
That's really cool. Definitely keep me updated on what you find. All right. So you do your cross-face nerve graft, you do your first stage, and then how long are you typically waiting between your first stage and your second stage? So actually doing the free muscle transfer.
I think it ends up being longer than 6 months and then closer to 1 year. And especially in the children, I think it ends up being closer than 1 year. I think we would be able to do it sooner. I think it's more coordinating and scheduling and my practice. But I think 6 months at the earliest, I would want to check for strong tenelles. And if it's going to be only innervated through the cross-facial nerve graft, like in pediatric and children, I tend to wait closer to 1 year.
Okay. And then you said, but predominantly most of your patients, you're doing dual innervation with the cross-facial nerve graft with nerve to the masseter. How are you then connecting those? How are you doing those coaptations?
Great question. And so it's always an end-to-end for me. And I try to prioritize the trigeminal and the masseter to innervate the free muscle, and then find a way to incorporate the cross-facial nerve grafts. Often this will mean that the masseter...
end-to-end masseter to obturator, and then end-to-side cross-face.
It's end-to-end for both.
Okay, so you're putting them both together into...
Yeah. So even though it's usually like the obturator would be like a one-to-one match with the cross-facial nerve graft, I think what I'll end up doing often is I'll put the masseter there, and then either I'll make it slit further down more proximally, where I will then connect the cross-facial nerve graft end to end there, or it'll be the opposite, where the masseter is closer and I'll end up connecting the masseter here and then end to end on the other axons to the cross-facial nerve graft.
Do you ever worry about masseter overpowering your cross-facial nerve graft?
Yes. So I think for me, the priority has been like getting them a smile and getting the muscle movement. So I know I'm biased towards having it be successful And so I'm biased towards prioritizing masseter. And so does that come at a cost of spontaneity and cross-facial nerve graft? Probably. And I don't think we truly know what is the best way to put those nerves together.
What are you doing in terms of vectors? There's been talk of dual vector, multi-vector. Many people are still just using, getting great results with single vector. What have you tried? What are your thoughts?
One vector that I don't have a lot of experience with free muscle would be the lower lip, but I do think that there's some really cool innovations coming up with how do we recreate the depression of the lower lip, or the DLI action when we're smiling. And Mesa and Nier has shown some beautiful results doing free gracilis that have both a vector going to the upper lip and then a vector going to the lower lip. I've been using some static suspension, but I think we will see more and improved outcomes for the smile with lower lip considerations.
Yeah, there's so many nuances on how, what constitutes a spontaneous smile. How can you make that smile, natural, what people are looking for. So I think all of these, different avenues are really exciting to see, what is the best way that we can restore people as best as possible.
So just before we switch on innervation, so I mean, for me, for sure, my most common one is dual innervation with cross-facial nerve root and masseter. I do sometimes do the cross-facial nerve and the masseter as a single stage if the patient really has a strong preference, but I prefer to do it in 2 stages. Theoretically, it makes me feel like the accents are going to be more readily at the distal tip of the cross-facial nerve graft, but there is the option of doing them at the same time as a single stage. I don't think anybody knows which way is more successful. And then for children, I tend to do cross-facial nerve graft only. I really think that they are able to get a better result for that, and that it will be more spontaneous, and that they'll use it more if it's based on a cross-facial nerve graft, unless it's a Mobius patient where we don't have that option. And then for adults, I really think that the cross masseter has completely changed my practice. So in people who are nerve depleted, where I don't have the masseter anymore on the ipsilateral side, I put a cross masseter, cross facial. So it's a single sural that will have both the masseter and the facial nerves coming through. And I'll use that for the free muscle. And I mean, a game changer for my people that before I was trying to do cross-facial nerve grafts on older adults in their 60s getting disappointing results. The cross masseter has changed that for me. They are getting really nice smiles. And I have 5 people that have had that done. And I've been really surprised and impressed by it. In another advantage of the cross masseter is that you don't have to go as long with the nerve to go all the way to where the masseter is. If you're doing a cross facial, you'll want to try and go as long as you can so that the coaptation of those nerves that we were discussing, like how do we put them together more optimally, the geometry is more favorable. If you're doing a cross masseter, you hopefully also with some facial nerve branches in there, I'm able to end here in the frontal incisor and then bring the obturator to it. So the distance is also a little bit shorter.
And I also think that's important just in terms of how much, how well and how quickly they're reinnervating. Because I mean, when you're adding such additional length that the nerve has to grow across, I can't help but, hypothesize that that's going to affect your final outcome.
I think I've heard Dr. Jewett really feel very strongly about that shortening the grafts is going to lead to better outcomes.
Mm-hmm. Yeah, I mean, it's all stuff that, I think also because this procedure is, just more rare, that it's hard to really pull these out, determine outcomes at a single institution and what is really the best method and why there's so much variability in terms of how people are doing it.
Yeah, like rapidly evolving, and then a lot of nuanced little things that can affect the outcome. That's part hard. Of what makes it exciting.
When you're just building your own practice too, you're just trying to figure out what works for you. So there are different types of, in terms of the design of the muscle and the transfer of the gracilis, there have been different ways described traditionally, a single vector, but there's also been dual vector as well as multi-vector. What do you routinely use in your practice? And what are your thoughts on these different variations?
Yeah, so I definitely started as a single vector person that prioritized the oral commissure and lifting the oral commissure to create the smile. And I really have transitioned to doing at least 2 vectors and to insert not just to the oral commissure, but also to the middle of the upper lip to help that upper lip displace superiorly, kind of move superiorly with the smile and increase the dental show. And I think it makes the results just that much better. And I really credit Patrick Byrne and Kofi Boheni, big mentors for mine, for making that innovation and that change in the design. So I'm definitely a multi-vector proponent. And if I'm doing those 2 vectors, I might even add a 3rd vector to the lower eyelid. And the lower eyelid, I was a little bit skeptical about how much contraction we would get there and how much vascular perfusion we might still have on that small little tiny 3rd vector. And the more we do them, the more we find like little tiny perforators where I can even Doppler the 3rd vector. So I've been really happy with those. It gets tricky to design the length.
Yeah, how are you designing that?
Yeah, I'm still tweaking it and trying to make it better. But I put the most important vector as the one that goes to the oral commissure, and it'll inset a little bit more laterally. And then I'll have smaller vectors that are coming closer to the anterior face of the maxilla for the 2nd vector, and then the 3rd vector trying to come all the way across the eyelid. I just finished writing a review that has some diagrams and intraoperative pictures, and it's going to be in press soon. I know it's Elsevier, so it must be Facial Plastics Clinics of North America. So I think it'll be impressed soon with some photos and diagrams.
Essentially, you're trying to create that narrowing of the eye that you naturally get when you smile.
So for the 3rd vector, I'm trying to recreate that kind of squinting that we get with the smile.
Yeah. Okay.
So that you don't have like a kind of wide open eye looking at you.
Does it help just in general with their kind of lower, ectropion?
Yeah, I find that I'm still having to do the ectropion repair. It's just that I'm using the muscle as part of the repair. So I don't, similarly to nerve transfers, where I expect somebody that has a successful 5-7 to get lower eyelid contraction. They will get tone, they will get contraction, but I don't expect that to correct the ectropion or lower lid malposition, similar for the free muscles. If the muscle gets reinnervation and is successful, I think we will see contraction there. I don't think this by itself will fix the position of the lower eyelid.
What are you routinely doing for your lower eyelids?
I'm very lucky that my co-director for the Facial Nerve Center is John Ng, who is the director of oculoplastics at the KCI Institute here at OHSU. And it can be hard to get oculoplastic surgeons with their busy schedule where they do multiple small little cases to come to an all-day free muscle reinnervation, but he makes it work. And so he's with us to help us inset with the medial canthus, and he does most of them. I think it's what we all do for lower eyelid, release the lateral canthus, reposition it where it needs to go, realize that it's not just pulling from the lateral canthus, but also the actual eyelid with the orbic, even if it's denervated. So I used the 2 or 3 vectors when I'm using the gracilis. I really think it's made my results better. One of the things I want to look at is, am I making the faces too bulky as I'm creating?
That was in the next question. So with 3 vectors, how much bulk are you getting with that in their face?
Yeah, so I think one of the things that Dr. Hadlock did beautifully, and that I feel like she taught all of us, was how to make a gracilis small enough that it could fit in the face, yet strong enough that it could smile. And the multi-vector is certainly a bigger flap. And so I was putting in single vector gracilis that were around 16, 18 grams. And my multi-vector gracilis at the time of inset are more like 35 grams. Mm-hmm. So one concern has been, am I now going to make their faces really bulky? Like their smile is going to be really wide, but is their cheek going to look really bulky? I haven't found that, but I am in the process of looking more critically, like really measuring the photos and looking at that.
And where are you anchoring your vectors to the oral commissure and the upper lip? Laterally, where are you anchoring them?
The first vector, or the vector that suspends the oral commissure, goes to deep temporal fascia, and then the second vector ends up going a little bit to like the most prominent part of the zygoma, so it's a little more anterior, and that becomes the pivot point for your 3rd vector. So I'm trying to end up around the maximal projection of the maxilla a little bit superiorly, a little bit anteriorly, if that makes sense.
So where are you noticing muscular bulk? Is it kind of where your second and third vector are, or is it still in that traditional kind of above the zygoma?
I think one of the things that I've noticed, we have been somehow, I think this last patients that have been doing the multi-vector have had fuller faces, and I have not noticed excessive bulk. So I think because this muscle is going to become denervated and atrophy and then get reinnervated, it's not quite as bulky as I thought it would be.
Yeah, it's definitely something that is challenging just in terms of figuring out the weight of it, but also trying to keep it so it's not getting scarred to the overlying skin, getting kind of that dimpling, when they smile.
And I tend to insert deep and to do all of the dissection pretty deep. So,
to avoid that.
I think the thicker I make the skin flap, the less I've had
less likely you are to get that.
Yeah.
What would you say is your biggest challenge with the procedure? Is there something you can identify that, you really would love to improve upon it, or something that you just haven't been able to completely tackle?
Yeah, I think the finesse of the muscle design and the inside, as you need to be somewhat flexible and follow the perforators in the nerve pattern as it's going into the muscle. And so I wish I had a recipe where you could come in with a template and you just cut it to that template. But I think being flexible with the perforators and then adjusting that design of where the vectors are going to come in, I think that's still the area that is more the art of surgery and the finesse that I'm working on.
I kind of want to segue into, we talked about different types of muscles that can be used. Previously, latissimus has been used, serratus gracilis, but also Dan Allen published on using the sternohyoid. And now recently you've published on using composite sterno and omohyoid. And, the advantage of, using your next, your strap muscles is that, as we were talking, the gracilis is big, it's bulky, it's also a different type of muscle compared to your facial muscles. The strap muscles are very similar in size. They're close to the operating field, and then they're of similar muscle type to the facial muscles. So tell me about this. What made you venture into trying this flap? How was it? What did you think? Do you think you're going to try and incorporate it more into your practice?
Yeah, so we have been doing free strap muscles for dual vector reinnervation at OHSU, and we're playing with making the omohyoid also be a third vector. It's something new that we're doing and exciting. So we've been doing it for 4 patients that have had good movement, but that is the total number of times that we've been doing it. And I should mention that I don't do these free muscles by myself. I am always doing them with a team. So Lori Howell, Mark Wax, and Ryan Lee helped me harvest. And really Ryan, who is my husband, is the lead on harvesting the free strap muscles. And so it's sternohyoid and omohyoid. And I really learned this technique from Mark Homan. So talking to Mark Homan at Madigan Army Center, they were already doing it and they had at least 10 cases under their belt. And he really encouraged me to do it. It was something that we've been thinking about for a long time. And we've been really impressed and really happy with them. So the sternohyoid and the omohyoid will already be covered in their fascia. So there will be no need to do dissection within the bulk of the muscle. And then once they're harvested, they're really small flaps. So they tend to be around 20 grams. And just as we were talking about the adhesions between the muscle and the skin, these are already covered in their fascia, which should allow them to move and not adhere as much as a free raw muscle edge might. So the sternohyoid has been our vector 1 from the oral commissure to the lateral area, and omohyoid, which is long, has been our vector 2. We're mostly discarding the posterior belly, and then we're plicating it. And where we're plicating is just where we're seeing that opportunity to work on the lower eyelid. There's no leg wound, so it doesn't affect their ambulation. I had a patient that ended up on a trip to Europe a month after having their free strap muscle. And they're strong, they're moving well and smiling. I think I need more experience. not every patient will be a candidate. Definitely our head and neck cancer survivors won't have the step muscles and the vascularity.
Can you explain why? What nerves are you using? What nerve is based off of what artery?
Yeah, so I think the challenge in this harvest is that it's a very meticulous dissection with small perforators. And so the challenge really is the arteries and veins. And we've been using superior thyroid artery, common facial vein. We've mostly been able to identify 2 veins. So thyroid vein was also used. And the innervation, which was really your question, has been the free strap muscles have the advantage that they are already made to have dual innervation. So you have ansa cervicalis and you have ansa hypoglossy, and they both innervate both muscles.
And also, are you doing this as one stage? Because technically it should be long enough.
Oh, I haven't brought one over to the. I haven't brought it over to the contralateral, the nerve long enough to the contralateral. I haven't done that, so I've been doing them as 2 stages. I've done them as a single stage for a rescue for somebody who were doing a cross masseter. I see a lot of potential and advantages on using the free step muscles. They're compact and small, and they're already covered in the fascia. So when we're fully harvested, it's around 20 grams. We'll use the sternohyoid, which is the stronger muscle for the oral commissure, and then the omohyoid for the upper lip. And you can plicate it and start using it for the lower eyelid. The challenge is in the arteries and the veins.
Yeah, because they're considerably smaller, I would assume. So what are you, or what is the team in setting them into?
So we've done both, where we've gone to STA and superior temporal artery and vein, and we've also gone to facial, and so we've made those work. So it's more the veins coming from the harvest and not injuring them during the harvest. And then the free strap muscles will come with ansa hypoglossy and ansa cervicalis. So you are able to do dual innervation if you want. We have only done it in 2 stages, so I put a cross and then we connected. Theoretically, you probably have enough length to do it as a single stage and put a smaller cross over. And we've done it at a single stage when we're doing single innervation. But because you have 2 nerves, it's really an ideal setting for dual innervation, and both nerves will innervate both muscles.
Have any of those patients been out long enough for you to see outcomes? Or, I realize, in terms of comparing, it's too limited, but any thoughts?
Yeah. All of the 4 that I talked about are all moving. So they're all out long enough that we know that they're having movement and excursion. So I'm on the process of comparing my multivectors to the straps. And so hopefully I'll have more information for you guys.
Was there any difference in terms of time to movement between in just your regular practice, that way what you saw?
No, there really wasn't. I haven't done that many cross masters, and one of my straps is a cross master. But I was impressed that even the cross masters were starting to get movement within that 3-4 month mark that you would expect for somebody that has masseter as part of their innervation.
Yeah. I mean, I think that's really cool. And I think it was something that I first learned about it. I do mission trips with Dan Allum, and so he was talking about how he used that a lot in his practice, or he still does it in Hawaii. But just, intuitively, it, makes a lot of sense because they're a lot similar in size. He had done some histologic work in terms of the type of the muscle, and so it could be something really, awesome to see if that's an evolution to something different.
I've been really impressed and really happy with them, and I know that Dr. Hellman continues to do them, and it's his preference. Like, he will always choose a strap if it's an option over a gracilis. I haven't had to abort anyone yet, but I do talk to people about that. Like, if we don't have the proper vessels, we will have the option of going to the leg. It takes a certain type of patient to want to do something that is relatively new and innovative versus something that's tried and true.
It's really hard because these patients have already gone through so much. And, it's, they're just trying to get their best shot. So I can imagine how it would be hard to find the right candidate for these flaps. But
I do think we're going to see more of them. And hopefully one coming from you, Shai, soon.
I mean, I've heard that the dissection is quite tedious, and I don't, do that personally, but I think it would be really cool. So, I know we've been going for quite some time, but this has been awesome, Myriam. It's really, we always talk about it at meetings, and I love hearing just the way you do your practice, how you do things differently, bouncing out ideas,
Thank you, Sally. I think we're going to get other people who do the surgeries to like chime in and listen. So hopefully I'll get some feedback on how they do it and get tips from other people, because I think a lot of the things we talked about are kind of that border between like, we know we have good evidence, or this is how I do it. So thank you for asking my thoughts on this. This has been an awesome conversation. I could keep going on it.
Yeah, I'm so happy that you were able to join us today. It's hard for us to connect just given we're cross country, but if people want to find out more about you, they can find you at OHSU. Do you have a social media account if they want to learn more?
Yeah, it's Dr. Myriam Loyo in Instagram, and then the OHSU webpage as well.
Awesome. Well, thank you so much for joining us today.
Thank you.
Thank you so much for listening. If you haven't already, make sure to subscribe, rate the podcast 5 stars, and share with a friend. If you have any questions or comments, direct message us at _Backtable ENT on Instagram, LinkedIn, or Twitter. Backtable ENT is hosted by Gopi Shah
and Ashley Agan.
Our audio team is led by Kieran Gannon, with support from
Aaron Bowles,
Josh McWhirter,
and Josh Spencer.
Design and digital marketing led by Brian Schmitz, with support from
Taylor Spurgeon Hess.
Social media and PR by Chi Ding.
Administrative support provided by Judy Dela Cruz.
Thanks again for listening, and see you next week.